Don't need my glasses. Good morning, everyone. Thank you to the VCCC for inviting me along today to speak about our experience at Peter Mac on Carty cell therapy. Just to give you a little bit of background, Peter Mac has been leaders in the concept and developing Carty, and predating back to the mid-1990s, where the Cancer Immunology program first developed the concept of Carty cell therapy. Since then, there's been a strong investment in preclinical research and clinical trials. And you can see there in 2007 was the first Lewis Y clinical trial. Another example of the clinical trial involvement is the Chimera Juliet clinical trial, which was an international trial for adult diffuse large B-cell lymphoma that was relapse refractory or had relapsed following an autologous stem cell transplant. There are a total of 93 patients infused with Chimera, and of those patients, 40% reached a complete remission and a further 12% a partial response. So these findings led the United States of America Food and Drug Administration to approve the use of Chimera, and subsequently in November 2018, the Therapeutic Goods of Australia announced approval for Chimera in both adult diffuse large B-cell lymphoma and in pediatric, adolescent and young adult acute lymphoblastic leukemia. So what is our access in Australia, and who cannot access Carty? So essentially there's a range of clinical trials currently available, and they're predominantly in the haematology setting for diseases like diffuse large B-cell lymphoma, follicular lymphoma, chronic lymphocytic leukemia, and Richter's transformation. And in the near future, trials for mantle cell lymphoma and multiple myeloma. In the medical oncology setting, there is one phase 1 clinical trial that requires solid tumours to express the Lewis Y antigen. And there's hope in that medical oncology space to increase clinical trials for these patients in the future. So I've mentioned about the TGA approval in November last year, and it obviously was an approval for the pediatric and young adult ALL population, and also the adult diffuse large B-cell lymphoma. So these are patients with multiply relapsed disease or relapse following an allogeneic or an autograft. So currently, though, there is a funding mechanism for the ALL indication. However, there is no current funding for Carty for patients with diffuse large B-cell lymphoma. However, it is under consideration. So for those patients with diffuse large B-cell lymphoma, we have been utilising a program called the Medical Treatment Overseas Program, or MTOP. This program is a government-funded program whereby a patient is referred to an overseas centre that offers Carty as standard of care. If they're accepted, then a referral or an MTOP application is submitted to the Australian government. The patient is the costs of therapy are funded for the patient, and a carer or next of kin is also funded to travel with them. As you can imagine, the duration of therapy is approximately 3 months, dependent on toxicities. So for patients that have multiply relapsed disease, the physical and psychological impacts of travelling overseas out of your support environment for that minimum of a 3-month period can be extremely difficult. Patients have been extremely privileged and extremely happy to be able to have that opportunity. However, ultimately, they would prefer to be in their home environment with their support system accessing care. This is a case study of a patient that we have infused recently, and I have Lucy's permission to share her story. So you can see diagnosed at the age of 10 and has had multiple relapses. So a total of 13-year cancer journey and 6 relapses of her disease, including a relapse following an allogeneic stem cell transplant. In June this year, Lucy was referred for consideration of Carty cell therapy. She was from interstate and travelled across to Melbourne and remained there for approximately 4 months for her care. Her cells were collected and they were shipped overseas to be manufactured. Cells at the moment are currently being manufactured in the United States of America, and there's approximately a 4 to 6 week turnaround for the chimera product. In diseases such as acute lymphoblastic leukemia, it can be very difficult to bridge and keep these patients well and alive during this time. Lucy ultimately received her infusion and developed the toxicities that we've just heard from Helen, so that of cytokine release syndrome and immune cell-associated neurotoxicity syndrome, or ICANS. Currently, we're admitting these patients, and she was admitted for approximately 2 weeks and then was followed up in the outpatient setting and continued her care there. So in terms of our clinical delivery, a Carty service is a multidisciplinary approach. It's not just a haematology service, it's not just a cell therapy service. It's engagement with many services. Neurology, for example, to help deal with neurotoxicity in patients such as Lucy. The intensive care unit who support patients, or the high dependency unit who support patients undergoing cytokine release syndrome. There are also lots of other allied health services that are integral in the care of these patients, such as the on-track or youth cancer service, social work departments, nutrition, physio, to name a few. Ultimately, the care of these patients and engaging these multidisciplinary services ensures the patient safety. On the right hand of these slides here are tools that we've developed in-house that help assess ICANS, or the neurological toxicity phenomenon. These tools can be used by carers if patients are in the outpatient setting, but they are also used for staff, so they can early recognition and identification of toxicity. Ideally, essentially, having these protocols in place, having these deteriorating pathways ensures that patient safety is paramount. So from a broader perspective of our cellular therapy service, the development of our cellular therapies program has focused on implementing new roles rather than embedding them within existing workforce. An example of this includes our logistics manager, Shay Disney, who operates the cells and coordinates them being sent and manufactured off-site and the receipt of the cells. Much more complex than I've just summarised. Other examples include roles including an addition of a cellular therapies fellow and my own role as the nurse consultant of Carty. Essentially, implementing such roles would not have been possible without the cellular therapy strategic plan and executive support. And ultimately, these roles enable service planning and ensure patient safety and delivery of care is the ultimate. Another thing that we do on a weekly basis within our Carty service is a Carty prioritisation meeting. It's a weekly meeting with the haematologist and apheresis nursing and the logistics manager. This meeting is an example of precinct partnerships. It involves 2 external haematologists on board to discuss patient referrals, patients during their manufacturing process and following infusion care. Other additional examples of precinct partnership is sharing such materials as our ICANS tool that we've just shown on the previous slide, and also our internal toxicity management policies. So here is just a picture to demonstrate a Carty continuum. So there's multiple steps to the process that a patient undergoes. And you can see that it, within each step, involves multidisciplinary teams and multiple departments. We need to support these patients not just physically, but also from a psychological aspect throughout each step of this complex process. During this time, we're not only treating and supporting patients, but also dealing with the logistics surrounding their cellular therapies product. Challenges include manufacturing failure with an approximately 20% rate in some of the Chimera products, and also disease progression during this time. The immediate onset toxicities such as cytokine release syndrome and neurotoxicity have already been mentioned, so I won't focus on them. But this Carty continuum is a diagrammatic example of the multidisciplinary approach to Carty therapy that services require. Referring back to Lucy, she was an example of potential complexities of care. From a logistical perspective, she travelled interstate, relocated with her family for the duration of care, and psychologically was experiencing her 6th relapse as a 23-year-old woman. After a 13-year cancer journey, and although some toxicities, Lucy ultimately reached a CR at 1 month. We're now transitioning to her 2-month follow-up with restaging at 3 months, 6 months and 12s. The future now looks bright for Lucy as she plans to return home, get back to the gym, go on her trip to Southeast Asia, which was planned in June this year with her boyfriend, and continue life as a young woman. I'd like to thank you all for the invite today, and would encourage anyone from external centres in Australia that are setting up CAR-T services, whether it be in a clinical trial or as a commercial access, to contact me if they are interested in sharing resources or perhaps education as well. For any clinical CAR-T inquiries, the email address below is for any patient-related or clinical trial access. Thank you.